Welcome to this explainer. Today, we're taking a massive, clinically dense master guide on diabetes management and transforming it into a streamlined, high-yield toolkit. Look, if you work in healthcare, if you're studying medicine, or even if you're managing diabetes every single day, you know that keeping all these guidelines straight can feel like an absolutely impossible task. Have you ever felt totally overwhelmed by the sheer volume of facts, warnings, and mnemonics in diabetes care? Because trust me, you are not alone. It's one of those fields where a tiny miscalculation can literally lead to a life-threatening emergency. But on the flip side, having the exact right knowledge at your fingertips can completely turn a patient's life around. So let's open up our clinical toolkit. Here is our agenda for today. 1. Monitoring and targets. 2. Mastering insulin therapy. 3. Type 2 diabetes medications. 4. Diabetic emergencies. And finally, 5. Managing special clinical situations. Let's kick things off with Section 1, Monitoring and Targets. Our absolute go-to for a long-term metric is HbA1c. But to really get what it's telling us, you have to remember what it's actually measuring behind the scenes. It's the non-enzymatic glycation of hemoglobin over a 2 to 3 month period. Because this is directly tied to the roughly 120-day lifespan of red blood cells, any condition that messes with those cells is going to alter your reading. Think about hemolytic anemias, transfusions, or even race. Like HbA1c in African Americans naturally runs a bit higher at the exact same mean glucose level. You really have to know when you can trust your dashboard and when you need to pivot to an alternative like fructosamine. And this right here brilliantly illustrates how our targets absolutely must shift depending on the patient in front of us. We aren't aiming for a one-size-fits-all number. For most patients, sure, we want an HbA1c under 7% to balance the benefits and risks. But notice how we allow a much looser control, up to 8%, for elderly or complex patients where a hypoglycemic fall could be, well, devastating. On the other hand, we demand incredibly tight control during pregnancy because the risk of fetal malformation spikes dramatically if control is poor around conception. Now, stepping away from that 90-day snapshot, we have real-time monitoring. When you compare continuous glucose monitoring, or CGM, to traditional blood glucose monitoring, the biggest thing to remember is that a CGM measures interstitial fluid, not capillary blood. And that means there's a slight time lag. So if a patient's glucose is dropping or spiking rapidly, say they're in the middle of an intense workout, their CGM might actually be a few minutes behind what their actual blood sugar is doing. Moving right along to Section 2, Mastering Insulin Therapy. Okay, check out the golden rule hidden within these durations. Rapid-acting analogs, they are almost always preferred over short-acting regular insulin for meals. You want your patient injecting a rapid-acting analog just 10 minutes before they eat to get that optimal post-meal coverage. We essentially reserve regular short-acting insulin strictly for IV infusions when they're in the hospital. You might be wondering, how do we actually make insulin rapid or ultra-long-acting in the first place? Well, it's all about some very clever molecular tweaks. For rapid insulins like Lispro, we essentially reverse amino acids to stop the insulin molecules from clumping together, which means they absorb instantly. For Glargine, we change its chemistry so it microprecipitates in the tissue and slowly dissolves over 24 hours. And Deglutic? It forms these multi-hexamers that bind to albumin, extending its duration way past 42 hours. These targeted tweaks are exactly what let us perfectly mimic a healthy pancreas. But as with everything, advanced technology comes with its own risks. Listen closely to this clinical pearl because it's a big one. Patients using continuous insulin pumps only have rapid-acting insulin in their system. The pump just delivers it constantly to act as a basal rate. So if that infusion site gets blocked or the pump breaks, they don't have a 24-hour backup of Glargine floating around. This means diabetic ketoacidosis can set in frighteningly fast. All right, shifting gears to Section 3, Type 2 diabetes medications. To fight off that exam fatigue and clinical overwhelm, really, we need to categorize this massive list of drugs based on what they actually do to the patient. Let's anchor your memory to the acronym BAGDS. BAGDS. This groups together all the drug classes that rely on glucose-dependent mechanisms or act independently of insulin secretion. Because of how they work, the drugs in this mnemonic won't cause hypoglycemia on their own. On the flip side, you really need to know which drugs are going to actively frustrate your patients by causing weight gain. Use the mnemonic CITY to instantly recall the major culprits here: sulfonylureas, insulin, TZDs, and glutamides. Knowing this off the top of your head helps you tailor therapy, especially for patients where weight management is a primary goal. Now we have to talk about the absolute heavyweight in type 2 diabetes management, metformin. It's universally our first-line agent, and for good reason. It's cheap, it's effective, and it's weight neutral. But it's not without risks. You absolutely must memorize HAFLEB to know exactly when prescribing it could be dangerously toxic, mainly because of the risk of severe lactic acidosis. For example, if a patient's GFR drops below 30, or they're heading into surgery with contrast dye, you have to stop the metformin immediately. Here's a fantastic exam tip. When you're dealing with alpha-glucosidase inhibitors like acrobose, it really comes down to basic plumbing. These drugs work by blocking the breakdown of complex carbs in the gut. So, if a patient on this medication accidentally takes too much insulin and crashes, feeding them a piece of bread or a candy bar with complex sugars isn't going to save them. The drug is actively blocking their digestion. They need pure, simple glucose to recover.
Let's head to the ER for Section 4, Diabetic Emergencies.
In the emergency room, you're mainly going to face down two massive crises, DKA and HHS. Putting them side by side, you can clearly distinguish DKA's rapid, highly acidic, nauseating onset in a younger type 1 diabetic from HHS's incredibly insidious, slow-building presentation. HHS typically strikes elderly type 2 diabetics, leading to these massive glucose spikes. We're talking sometimes over 1,000 milligrams per deciliter. It causes profound dehydration and coma, but notably, it skips the severe ketosis or acidosis you see in DKA. When you're treating DKA, you've got to be incredibly systematic. Just follow this strict 4-step protocol. Fluids first, always, to fix the massive deficit. Then start your continuous IV regular insulin, but keep a very close eye on the potassium. Insulin and fluid correction will drive potassium right back into the cells, so you must replace it to avoid deadly arrhythmias. And notice step 4, we rarely give bicarbonate unless the patient's blood is dangerously acidic, like below a pH of 7.0. The acidosis actually resolves way slower than the blood sugar, which is exactly why we eventually add dextrose to the IV fluids. That way, we can keep the insulin drip running long enough to completely clear out the ketones. I want you to take a mental snapshot of this warning right now. The biggest non-metabolic danger during DKA treatment isn't actually the diabetes itself. It's us. Overcorrecting fluids and blood sugar too rapidly, especially in pediatric patients, can lead to fluid shifting dangerously into the brain, causing fatal cerebral edema. Which brings us to a very sneaky, modern phenomenon known as euglycemic DKA. Normally, DKA comes with sky-high blood sugar, right? But SGLT2 inhibitors work by forcing glucose out through the urine. This means a sick patient can be in profound, life-threatening ketoacidosis, and yet their blood sugar looks perfectly fine on a monitor. The glucosuria completely masks the hyperglycemia. So the main takeaway here? Always check ketones in a sick patient if they are on an SGLT2 inhibitor. Finally, we arrive at Section 5, Managing Special Clinical Situations. When your diabetic patient is admitted to the hospital, the rulebook completely changes. Thanks to the landmark NICE sugar trial, we now know that aiming for perfect tight blood sugar control in the ICU actually increases mortality because of severe hypoglycemic events. Moderate targets of 140 to 180 are way safer. We also stop oral agents on admission, and we absolutely never rely on just a sliding scale of insulin. You must use a proper 3-part regimen of basal, prandial, and corrective insulin. We all know exercise is fantastic for patients, but it drastically alters insulin dynamics. For athletic patients, simple education is life-saving. If they're about to go for a huge run, they should absolutely not inject their insulin into their thigh. The increased blood flow to that exercising muscle will absorb the insulin rapidly, leading to a catastrophic crash mid-workout. You always want to inject into a non-exercising area. So, we've unpacked the clever molecular tweaks, the massive drug class mnemonics, and the strict physiological protocols. But when you look at the rapid rise of hybrid closed-loop pumps and AI-driven algorithms, it really leaves you wondering, how long before technology completely automates everything we just went over in this explainer? But hey, until that day comes, having this structural toolkit memorized is your absolute best defense against the complexities of diabetes. Thanks for diving into this with me, and I'll catch you on the next one.